You're listening to the OrthoK podcast. The OrthoK podcast is sponsored by the Orthokeratology Academy of America. Go to www.orthokacademy.com.
Welcome to the podcast. My name is Dr. Tom Wyszewski, and I'll be your host for this ongoing OAA podcast series. Just a bit of background about me. I've been involved with orthokeratology for more than 20 years, have been a member of the OAA since its inception, have served on the board of directors for the past 4 years, and the co-chair of the Mentor Committee, as well as the co-host for the Vision by Design Bootcamp.
On this episode of the podcast, I'm pleased to welcome Dr. Thomas Aller. Dr. Aller is widely recognized as one of the world's leading authorities on myopia control. He has completed randomized clinical trials in the use of soft multifocal contacts for myopia control and is possibly the foremost authority on the use of soft multifocals for myopia control in the world. He has collaborated with Dr. Brian Holden and Dr. Earl Smith and the Vision Cooperative Research Center in Australia in their efforts to develop and bring to market both spectacle and contact lenses specifically designed to control myopia progression. He has authored numerous articles on the topic of myopia control, and he himself has been an OrthoK patient since the age of 16. Now, I'm guessing that was more than just a couple of years ago. Dr. Aller, welcome to the podcast.
Well, thanks for having me. Yeah, that was quite a while ago.
Yeah, your OD must have been pretty progressive for his time.
He was, actually. He probably got me interested in optometry, and he was using the old-style daytime progressively flattening May and Grant method, or his version of it, and it was pretty cool to be able to see without glasses in that version.
And that's the old days of OrthoK. Things are a lot different today, obviously. But today we really want to talk about soft multifocals because that's really your area of expertise. I'd like to begin with just a brief overview. Give us the basics on how soft multifocal contact lenses can control myopia.
Well, I think it probably hasn't been established exactly what the mechanism is. When I started over 20 years ago, there was very little thinking or writing about the role of the periphery or peripheral defocus in myopia progression. Probably none, maybe save for Hoogerhide, which nobody ever seemed to have read before Earl brought it back to life. But it certainly wasn't something that practitioners were thinking about. And so what got me started was just the mismatch between what I was taught in school is that myopia is completely genetic. You can't do anything about it. It'll stop at age 16. And I went to Berkeley, so I thought my professors knew what they were talking about. But after a few years in practice, I was struck by the percentage of nearsighted kids and young adults that just kept getting more and more nearsighted. And it just I had to figure out were my professors wrong or was I a lousy optometrist. And confident fellow that I am, I concluded my professors must have been wrong and there should be a way to maybe control it. And so really what got me started was some of the studies in bifocal eyeglasses, most of which showed that they didn't really do much at all if you put them on any kind of child or a unselected group of myopic children. You'd get maybe 12-13%. It's hardly worth bothering with. And if you presented that to patients as a way to control their myopia, there'd be practically no way for you to demonstrate that you had any kind of effect, and it wouldn't really be worth it. So I pretty much abandoned using bifocal glasses until Goss and Grosvenor published an analysis that showed that they did, in fact, work for kids with esophoria at near. And so around about that time, early 90s, there was a fairly unimpressive bifocal soft contact lens that came out, but the occasions by Bausch & Lomb. But what was nice about it is it was meant to be a disposable lens. I thought, well, maybe I'll try this lens on these patients. And I ended up making it a quarterly lens so that it would be more affordable to try. And this is way back when it was really the same lens as the U4, which is worn for a year. So they were able to replace them 4 times a year. So I figured, well, that's better than once a year. And with those early lenses, I soon found out that they controlled nearsightedness quite well. And we did a retrospective study looking at 7 years of history with those lenses with Dave Grisham over at Berkeley. And, well, anyway, it convinced me if you're getting 80 to 90% reduction in the rate of progression, even in a retrospective study, there's got to be something there. And, well, that led to the randomized control clinical trial with Chris Wilsett at Berkeley.
What was your specific protocol, and what kind of results did you get?
Well, so we were still thinking about bifocal contact lenses as merely a more effective way to supply the add power that an isophore might like and appreciate at near, rather than an alternate way of controlling myopia through all its various other proposed mechanisms that have come out since. So because the studies had shown that an optical device wouldn't work for anybody that didn't have ESO, or maybe a high lag at the time, I felt it wasn't worthwhile to have any patients in the study that didn't fit the protocol of a patient group that would benefit from optical devices. So we did limit it to children and adolescents, age 8 to 18. They were all progressing in their myopia from their exam previous to the start of the study, or from their old glasses. They all had ESO at near, and actually what I ended up using clinically was the presence or the absence of ESO fixation disparity. And I concluded early on that esophoria wasn't really the issue. It was how well that esophoria was dealt with by the patient's binocular vision system. So that if they have esophoria behind a cover test, but they maintain perfect binocular fusion in real time, they don't really have a problem in my view. And in fact, probably a third of these patients had either orthophoria or exophoria by cover test, but they all overconverged in real time, leading to presumably accommodative responses to that esophore, presumably a reduction in or an increase in accommodative lag to deal with ESO, thus leading, again, presumably to axial hyperopic defocus, which was part of what we were looking at. So that was the patient population. We ended up with 78 patients, I think, evenly split into either single vision AccuView 2 or the original AccuView 2 bifocal at that time. The study was sponsored by Johnson & Johnson. So the results of that study is after 1 year, the kids that were in the AccuView bifocal progressed at 0.1 diopters per year, and the kids that were in the AccuView 2 single vision lens progressed at 0.75 diopters per year. And so that resulted in an 87% reduction in myopia progression in the treatment group versus the control. And these findings were matched pretty much by the axial length findings. We had an 80% slower axial elongation in the bifocal group at plus 0.05 millimeters per year, it's very minimal, and 0.24 millimeters in the single vision group. And in both the axial length data and the cycloplegic refraction data, there were significant numbers of these patients that ended up with both shorter eyes and reductions in cycloplegic refractions. So this was took a while to get this study published, but if it had gotten published when it first came out, it would have been quite interesting to be able to show that a growing child can have a shrinking eye just because of the introduction of an optical device. And it's still not well understood how that happens, but I see it frequently, and it's been reported short-term by Mike Collins in response to optical devices in humans, and it's been shown in some of the OrthoK studies as well. So it's very interesting results.
Yes, I have to agree. That's not something we would typically expect, that an eye is going to become shorter over time. Kind of interesting, though, the lens you use, the AccuView Bifocal, was not a center distance lens. It had annular rings, correct?
Well, I guess you could define it as a center distance in that it was distance near distance near distance near distance. So a 5-ring design.
Okay.
Interesting design. I mean, all of the contact lenses on the market that anyone has tried, including OrthoK and soft lenses and just about anything, with maybe the exception of the MySight, which is on the market as a myopia control lens in Asia. But most of the other ones were intended to be presbyopic lenses, and some of these lenses just accidentally could have been good design. So for kids, that is. The AccuView Bifocal, at the time wasn't a bad lens for presbyopes, but in a myopia control application, it's possible it had a pretty nice design in that the central zone for distance is rather small. The plus in that first ring is closer in than maybe some others. And you have multiple rings of plus that typically the kids didn't notice. I mean, it might have been that it was able to deliver quite a dose of plus in various regions of the retina. And in any case, as a myopia control lens, I certainly was impressed with the results. But over the years, I haven't really found a lot of difference between various designs, including near-center designs. And people in the OrthoK field, they, I think, assume that a soft lens and an OrthoK fit both control myopia in a similar way, and they probably do. They both affect peripheral hyperoptic focus, and certainly OrthoK is a center distance optical effect. But when I've used near-center lenses, and generally that's been the daily disposables, I haven't seen any difference myself, although I haven't done a head-to-head trial.
Well, let me ask you this. Do you have, in your own private practice today, a specific protocol that you'll use, a specific lens that you use, or a specific ad power that you recommend, something that maybe our listeners could take and utilize in their own practices?
Well, I would say that my general protocol is to consider myopia control for all myopic children and most progressively myopic adults. And the choice of the treatment is going to depend, I would say, to some degree on the age of the patient and their ability to wear contact lenses. So contact lenses, whether OrthoK or bifocal soft or the coming myopia control soft lenses, they're all dependent on whether a child can put them in and take care of them properly, and there are certain age limits there. Luckily, there's very little myopia at ages that kids have difficulty wearing contacts. So usually they might onset at age 8 or 9, and they're perfectly capable of taking care of either type of contact lens. But with any of these myopia control methods, you're really limited to changing the slope of progression. So if you want to have the maximum input or impact, rather, on the final prescription at the end of, let's say, college, where a lot of people are going to slow down, certainly, in terms of their myopia, you have to change the slope at the earliest possible age. So, in my view, there's not much difference between a myope that is progressing and a hyperope that's regressing rapidly. So that if you see somebody that is sort of rapidly decreasing in their hyperopia and they are less hyperopic at, let's say, age 8 than they should be, based on the clinical trials that have looked at that, you know that you have very likely a future myope. Well, it would be very hard to put a contact lens on a plus a half 8-year-old as an anti-myopia treatment, but there are some optical treatments that can be used at that age. Particularly if they have ESO or high lag, you can use a bifocal eyeglass, a large segment bifocal like the executive bifocals that showed pretty good results in that Canadian study, if you can get a kid to wear that type of lens. If they're the youngest child of 5 siblings, all of whom are minus 10 by age 11 or something like that, and they're a half diopter plus and rapidly decreasing, you might get a little bit more aggressive with them and start them with atropine if they're not ready for contact lenses. But parents would have to understand the strategy there. Otherwise, as soon as they cross over into myopia land, I start some kind of myopia control, whatever they're able to do. I think if you look at their research studies, and when you're practicing myopia control, you're a little bit out on a limb because there's no approved lenses for this indication, just a lot of research. So we're all entitled to practice off-label if the research supports it. But when you look at the research, you have to assume, with a few exceptions, that with OrthoK, with standard designs, you seem to get better results the higher the initial myopia. And this is presumably because there's perhaps a 1-to-1 relationship between how much you flatten in the center and how much peripheral plus that you get. And so most of the studies, although there are exceptions, show that there is less effectiveness in myopia control in the minus 1, 2, and perhaps 3 myopes, and then better control, let's say above that, and then, above minus 6, except for all the guys in the OrthoK Academy that are skilled at those levels, above minus 6, most practitioners find OrthoK to be a bit challenging to achieve good clinical results. So with that in mind, I tend to use bifocal soft lenses on the low to moderate myopes because you can put whatever peripheral plus you want, up to a plus 4. And between 3 and 6, I kind of have it as a you pick 'em for the patient. And above minus 6, I try to avoid myself OrthoK. So that would be my protocol as far as picking what kind of treatments.
Very good. Well, it was kind of interesting when I heard you speak last year, I believe it was, at Vision by Design. You kind of shook some of my own personal beliefs. My understanding of myopia control was that atropine and OrthoK pretty much were the strongest contenders at being able to control myopia. Your research seems to indicate that's just not the case, that soft multifocal lenses can be just as good, if not better.
Well, I think I haven't seen any research that shows that OrthoK performs better than bifocal contact lenses. Most of the studies out there, most of the studies are done by academics, and I'm more of a clinician than I am a scientist. So when I treat patients in the practice or when I design a study, I tend to design the study as a clinician might. So in that randomized study that we did, we didn't use the same ad on everybody. We used the ad for each patient that maximally neutralized their fixation disparity. And that isn't necessarily the only way that I practice now, because I've found, and after being influenced by Earl Smith, years ago, I stopped thinking that bifocal contacts would only work for ESOs. They in fact work for everybody, but I think they have multiple mechanisms. Now, practitioners will say when they do OrthoK, they very frequently have zero progression over time, and they're quite sure of that. And but the studies seem to suggest, on average, a 50% control. So, I think when it's easier as a practitioner when you have your own experience to quote, especially if you keep good records on that, you can with confidence tell your patients that, look, with these patients in this practice, when I use OrthoK, for instance, I rarely have to change the base curve. And if you explain that to patients, they can understand that's an indicator that you probably have good control. I think the studies use axial length changes over time, and that's, of course, the easiest way to track myopia progression with OrthoK. Just because it's very inconvenient to wash them out, just answer the question, what is their refractive state after 10 years of OrthoK? So I was inspired to do a little study on OrthoK versus bifocal contact lenses. It's not very definitive, with, I think, five subjects finished the study. But the design there was to start everybody with bifocal soft lenses for 6 months with cycloplegic refractions and axial lengths before and after. These were all quickly progressing myopes. I think they averaged a diopter and a quarter per year prior to initiating this treatment. And then after 6 months, we switched them all to OrthoK. And we just did it in that order because it would avoid the annoyance of having to do a washout in between the phases. And what we found is that there was a very dramatic change in the myopia progression in the kids that were wearing the bifocal contacts in the first phase. They actually ended up averaging a slight reduction in myopia, not much, 0.06. And the axial length data matched that as well. I think it was 0.01 millimeters in axial length change in 6 months' time. And then when we switched them to OrthoK, we just tracked the axial length with that. And what we found was, well, what I did is I looked at the refractive change prior to going in the study with single vision lenses and converted that to an equivalent axial length, which I figured was 0.23 millimeters. And then in the OrthoK kids, they had a axial lengthening of 0.06, which is also very minimal. The presumption was from those numbers in axial length is that they had a dioptric change of 0.2 diopters increase in myopia. So now both of those were dramatically better than their pre-treatment single vision standard of care lenses. But I didn't find that OrthoK was better than a soft lens in this study. And you can't really conclude the other way either with 5 subjects. But interestingly, and maybe not a surprise to OrthoK practitioners, at the end of the study, the kids were offered the opportunity to stay with the OrthoK or go back to the bifocal contact lenses. And with the knowledge in each of their cases, they did slightly better in terms of myopia control with their soft lens, and they all opted for the OrthoK, just for all the reasons that kids love OrthoK. And you're trying to provide a service, you're trying to help control myopia, you're trying to make their lives better and more enjoyable, and it's kind of hard to beat the overall results of OrthoK in terms of all the additional benefits. But a lot of patients aren't good candidates for it, or their prescription's too high, or let's say their prescription's too low, and you think you have to start with a more aggressive treatment. So I do use both methods. There was a study, so I also did a twin study years ago with bifocal contact lenses, identical twin pair, and was a dramatic change in the first year with bifocal contact lens. The twin that had the bifocal contact lens had a reduction in myopia, I think 0.12 or something like that. And her twin sister with standard single vision AccuView lenses had a doubling of her myopia. I think she increased a diopter and a quarter, diopter and a half, something like that. And then after she switched to bifocal contacts, she had about a half diopter reduction in cycloplegic refraction in her second year. So there was a study last year in Clio Journal by Cho that was a kind of a similar design in that she assigned one twin to OrthoK. I forget what design it was. It's probably a conventional design. And one twin to single vision lenses. And she also showed a change, a reduction in myopia with the OrthoK versus single vision, but the difference between them was nowhere as good or as dramatic as the difference between the twins wearing the bifocal contact lenses. I just haven't seen a study, one study, I guess, Eddie Chow's study, with a novel lens design with 6 curves and aspheric central treatment zone. He was able to show the same myopia progression control throughout the range of starting prescriptions. So I haven't seen that in print yet, but it's been presented at the last several meetings. So certainly an interesting study, but all the other studies, to me, don't demonstrate that OrthoK works better than what I see in my practice.
Okay, very good. Do you utilize atropine very often?
I would say no. I think, what I do is I would use atropine if the parents were concerned and if the child couldn't wear a contact lens of one sort or another. So that would be one application. And then I monitor the performance of whatever treatment that I'm using, bifocal contacts, OrthoK, and I have an IOL master, so it makes that easy to do. And if they don't hit the treatment goals, or they're falling short, and let's say if I don't have another optical design change that I can make, say with OrthoK, it's still a little speculative how you can change parameters to ensure you're going to get better results. So with bifocal soft lenses, you could go to a custom lens or increase the add. There are things you can try to boost the myopia control effect. So if I'm not hitting the treatment goals, I'll add atropine. And based on Jeff Cooper's work, I think came out last year, he looked at the efficacy of different doses of atropine versus the level of side effects and complications and annoyances like pupil dilation and cycloplegia, and found that the 0.02% was a nice mix of good efficacy and practically zero significant side effects. So I think he suggests that percentage for, standard cases, although he still, I think, suggests 1% on rapidly progressing or younger kids. He hasn't really found that they're bothered by those side effects, but I think most practitioners that aren't used to atropine, they'll probably be more comfortable with a low dose. So I do use atropine, just not very often.
Okay. And then when you do, it seems like it's more of an adjunct therapy, just if you're not hitting your goals.
Yeah, well, I think the proposed mechanisms for how atropine works and how the optical devices work, OrthoK or bifocal contact lenses, they're entirely different. So I hear people talk about, there are no studies to show that they'd be additive, but I can't imagine why they wouldn't be additive. They're entirely different mechanisms, so.
It would just stand to reason, yeah.
Yeah.
Okay. I'd like to talk about the future a little bit. At the Academy meeting, Professor Brian Holden announced a new soft lens design for myopia control. The lens, which is currently in clinical trials in China, is a daily disposable center distance peripheral plus design. Were you involved in the development of this lens, and can you tell us anything else about it? Or is that not something you can talk about?
Well, I could answer it carefully. The answer would be yes. I've been collaborating with them over the last, seems like, probably 8 years on various designs that have been tested in various ways, in soft lenses primarily, to try to control myopia. This last design that's in clinical trials in China is kind of the culmination of all of that work on all of those various designs with various partners over the years. Don't think I can get into the design other than how you described it, and you'll have to stay tuned for results. The announced plans are to bring that lens to market as soon as we get sufficient results out of the clinical trials for us to be confident that that's the lens we want to bring to market. I think expectations are it would be coming soon.
Okay, very good. So we'll keep our eyes open for that one. You know, in my conversation with Earl Smith, we discussed the peripheral defocus theory. We talked about how it's been pretty much established that by manipulating the focus of light on the peripheral retina, we can control eye growth. And that's the basis for using soft multifocal lenses, you know, to induce that peripheral plus power for slowing axial elongation and thereby slowing myopia progression. If we reverse this concept and use a soft multifocal or a soft lens of any type that induces peripheral minus power, we expect to accelerate axial elongation, thereby reducing hyperopia. I understand this has become your latest passion and that you have begun clinical trials to test this treatment. What can you tell us about this?
It occurred to me early on that these sorts of optical manipulations should be able to work in both directions. And I find that, I've been trying it for many, many years. I think in clinical practice the problem is you don't get 7-year-old +2 hyperopes coming in. They're really not having any problems. They're not complaining. They don't have strabismus or amblyopia. If you prescribe glasses for them, they typically might not even wear them at that age because of their robust accommodative system. It was a little bit different than my early myopia studies in that I didn't have a steady stream of patients that were willing to be subjects. So I accumulated a few cases in children that convinced me that it could work. I had also an identical twin pair that I did a more formal study on. I haven't published that yet because the findings were kind of hard to explain, and I'm still finding it hard to explain. I think it's possible there were some changes in the lens that resulted in the refractive changes that I saw that were not reflected in that case in the axial length as much as it should have been. So as soon as maybe I can figure it out or find out a way to describe it better, I probably should publish that one. But the most compelling case that I had was a 12-year-old girl that was a stable +3 hyperope for her whole life going back. I had records back from her previous practitioners. We put her into let's say an anti-hyperopia design, and essentially what I was using is a near-center bifocal contact lens where the total power through the central part was the subjectively acceptable distance plus prescription. So if she would take a +3, for instance, and be quite happy to take it and would wear an eyeglass and could see 20/20 without a lot of, forcing her to relax her accommodation, I might prescribe a +0.5 in the distance portion with a 250 add, for instance, netting out as a +3 in the center with a relative -250 add. So essentially it's manipulating the optical prescription of a conventional lens to create a negative bifocal. And in that case, we found that over 2 years' time, she dropped down to, I think, a +0.5, and her axial length was changing like a young Chinese myope. So it was pretty striking. We took her out of that lens, and she didn't continue into myopia land. She just hung out for the next 5, 6, 7 years at +0.5. So that would be one concern if you kick up a myopia progression thing with a hyperope. Are you going to turn them into a myope? And so I want to be cautious about where we stop these cases. So in the clinical trial, actually, I think I'm starting it today. I just got clearance from the IRB. It's being sponsored by Specialize. They're a custom soft lens manufacturer that does a lot of multifocals and torics, and they're just, as a practitioner, they're a great company to work with, by the way. Just a little plug for them, since they're helping me out with the study. But what we're going to do is we're going to do near-center designs with various configurations of peripheral minus. So to some extent it's going to be a customized type of lens, but it kind of fits still within what a practitioner could do with conventional multifocal lenses, from a custom manufacturer. And we're going to go 2 years with these anti-hyperopia lenses, and then we're going to have a single vision lens for the control lens, also from Specialized. And hopefully we'll find something interesting. I certainly would be pleased if that could be shown. I have tried it, by the way, just to let everybody know, on probably 20 adults with absolutely zero effect. So I wouldn't bother trying it with any adults. Earl thought maybe with an adult you'd have to really just shock them with something really bizarre to maybe jumpstart a growth process that's been quiet for many years. But I think it's not worth it. The thing is, adults would care about this treatment because they're bothered by being +2 at 30. And kids aren't all that bothered. So you do this treatment on kids that don't care about it, and 20 years later, they'll be happy that they did it. So clinically, it's just a little difficult to get kids interested, maybe.
Okay, well, let me ask you this. Have you considered this technique specifically with amblyopes?
I have had 2 amblyopes that I was hoping for some interesting results from, and I have a kind of a treated amblyope I'm working on right now. And sort of my dream patient came in before I realized that it wouldn't work for adults. She was a progressive myope on one eye and a stable hyperope on the other eye. And I thought, well, I'll just put an anti-myopia contact on one eye and an anti-hyperopia contact lens on the other eye. And after a couple of years, she'll be stable in her progressively myopic eye, and her hyperopic eye will become less hyperopic, and it just would be so cool. And half of it worked. Her myopia stopped progressing, but her hyperopia just kind of stuck there. So that's just convinced me it doesn't work with adults. I did have a child I wish had been more compliant so that I could tell whether it worked or not, but he was a amblyope and ISO hyperope, and the plan was to put him into anti-hyperopia contact lens and with a patch, so that we'd also be treating the amblyopia at the time. It's very non-compliant with a patch. I ended up trying a over-plussed contact lens on his good eye with a opaque tinted pupil, just to force him to use the other eye. He just didn't come back for follow-up, and I don't really know what happened clinically, but yes, I would use it with amblyopes, but when you're manipulating the optical zones and kind of forcing them to use the near center in these designs as a distance lens, you have to be careful to make sure that you're still providing close to 20/20 imagery in the amblyopic eye. Otherwise, you may not be helping the amblyopia. So in the clinical trial, we're not going to allow amblyopes unless they've been treated to where they can see 20/20 or I think 2020. So you have to be careful with that aspect of it.
Okay. Well, one of the main methods of determining whether or not you're getting progression is axial length measurement. And I know you mentioned that you have an IOL master. The average practitioner is not going to have an IOL master available to them. You have any recommendations for specific instrumentation for measuring axial length?
Well, I just wrote an app for the iPhone that'll do axial lengths, and I'm just kidding. Somebody will probably do that.
I'm sure.
Well, I think A-scan's pretty inexpensive. It's probably not necessary. I think it's nice to have. I just had it because it was provided as part of the study. I'm not sure I would have purchased it for $35,000, although over the years it's been very useful to have. Of more interest, scientifically, but also it's been useful in terms of practice management because the patients and the parents can see when there's either a shrinking eye, they're quite impressed with that, or show them the printouts and it's 0.01 millimeters of growth, and that's less than a stable growing child typically. So it's very useful to have. I think A-scans are fairly inexpensive. Practitioners that have the mythical friendly ophthalmologist in the area, they could, use their services to get some axial lengths if they had some cases where they thought it would be useful. But I don't think I'd recommend purchasing an IOL master.
All right, Tom. Well, that's been great. I really appreciate all the information. Before we close, is there anything else new and exciting, something else that you'd like to tell us about, or anything that's coming down the pike?
Well, we've been working all these years on developing myopia control lenses specifically to control myopia, and I keep thinking this will be the year, and I've been thinking that the last several years, but this will definitely be the year. I'm pretty confident. And so I anticipate that what's going to happen is that the Brian Holden Group has developed a novel multifocal contact lens with very interesting optics that I can't even think of how to explain, and also our myopia control lens, and we'll be looking for a number of optometrists in the U.S. as key opinion leaders to get these lenses before everybody else and to use them in their practice and get some clinical experience and report back to us so that we can help fine-tune the lens design or just help us to come up with strategies for how to launch these products. So we are looking for folks that are interested in getting in on the ground floor on these two products.
Well, I'm guessing that you're in the right place at the right time because we are the American Academy of Orthokeratology and Myopia Control. So we're the guys who've been singing this tune for years and years, and I guess you couldn't pick a better audience to, ask that question of. And I'm sure that probably most of our membership would be interested in taking a look at the initial look at some of these new products. So it's something we really look forward to and hope to hear more from you about in the future. So, again, I want to thank you for appearing on the podcast. I appreciate all the work that you do and the time you've spent with me today. Thank you very much.
Thanks, Tom.
You've been listening to the OrthoK podcast, brought to you by the Orthokeratology Academy of America. Go to www.orthokacademy.com. The music for this episode was done by Meredith Wilson and is used with permission.